And it's my pleasure to introduce my colleague, Dr. Tatjana Jakjovska from Macedonia. And she's going to talk about metabolic alkalosis as a first sign of cystic fibrosis. Please.
Good afternoon, everyone. Thank you very much for the Professor Yahya. Thank you for invitation to be a speaker to your conference. I am glad to present my work. I am pediatrician and I work with infants and also with cystic fibrosis. And I will talk for one sign which can everyone and in neonates and early infant in 1 month or 2 months, one recognition sign, so you can decide whether it can be cystic fibrosis in questioning the presentation. So what is cystic fibrosis? It is multisystemic disease. This multisystemic disease, which is caused or by mutation on the 7th chromosome and encodes the CFTR protein. So CFTR functions primarily as a chloride channel, and it controls the movement of salt and water into the cell and out of the cell in the affected organs. What is the problem? The problem is there are more than 2,000 different mutations, and genotype is not always resulting the same clinical presentation with the phenotype. So it's very difficult to identify a child or an infant with cystic fibrosis. So in the world and also in our country, we introduced 2 years ago the neonatal screening, but also the neonatal screening is not 100% positive. So we have a lot of positive, false positive and false negative patients. So when they are false positive, it is difficult with the psychological mind of the parents. It's very scary diagnosis. And after that, I have also some mothers, some parents, which are afraid of the diagnosis, don't believe that the child doesn't have. So we get to know each other and to speak a lot, or maybe to make the diagnosis by the mutations, for screening for mutations. But if you have false negative, so we have missed children with cystic fibrosis, which is very scary and very difficult. So these are 6 classes of mutations. So there are more than 2,000, but there are 6 classes of mutations. What does it CFTR protein does? So in the first 3 classes, it's a very difficult mutation because there is no protein. In the second one is no traffic, and the third is with no function. So these are difficult mutations with difficult clinical features. The other 3 are not so harmful because they have less function, less protein, and less stable. So when we get the new therapy, the Calideco, the Kaftrio, which are now we are using, so they can be more effective in the last 3. Here is one slide which I like because there are this is cystic fibrosis. So when they're talking about pulmonology should treat the patient with cystic fibrosis, I don't agree because it's multisystemic. It's not only the lungs. We have sinusitis, we have polyps, we have general malnutrition, maldigestions, if not corrected. So we have liver disease, we have um, vitamin deficiency, we have bone osteoporosis, we have meconium ileus, which you in the intensive care or neonatologist see. So I suggest, because you're a neonatologist and intensive care doctor, so if you have a little patient with meconium ileus, it is cystic fibrosis. So we have one little patient, because we started the neonatal screening. So on the screening, negative, and meconium ileus, he very difficult. After that, they did it again like a neonatal screening, again negative. But when we took the genetic, it was homozygote for delta F508. So this is very tricky disease. So if you have meconium ileus, please do the genetic. Yes, because new recommendations in the neonatal screening group in Europe cystic fibrosis group was took genetic. So when they take the screening, they took also the genetic at once. So it's the best the best way to find out is it or not cystic fibrosis. Yes, the gold standard is the salt, what we do, but the genetic is the best, especially when we have delta F508. We also have a lot of genetic mutations which are unknown. But if we have one of these, which we know, then we should suspect and search for more sequencing and etc. Because it's very difficult. Also, we have pathologists, maybe urologists, that if the couple don't have children because of male. Cystic fibrosis. It is a sign also for cystic fibrosis. We have hypersplenism, anemia. Uh, so Dios, when they're bigger children. So in them we also when so multisystemic, it's not only one disease, it's also pulmonology. What is the most characteristic for these children? Well, they're salted. So mother people can diagnose. So doctors, so I'm not waiting for that. Uh, and we in 2021 we have 100. So for this was what These are the genotypes we failed. We also find out they are fibrosis by this sign. So we have also the mutations, and you see these are not some of the very strong mutations, the bad mutations. So the typical clinical signs, what they have was vomiting. They were also vomiting. They were anorexia. They have weight loss, dehydration, and they were lethargic. They were lethargic, almost in coma. So, and they don't have any symptoms like CF before. So, warm weather influenced them bad. How you define, is it Bartter or pseudo-Bartter? So you have to look for the urine and the concentration of the metabolic electrolytes in the urine to make the difference. Also, we have sweat chloride test, was high, what is gold standard, and for defining if they are pancreatic sufficient or insufficient, we have the fecal elastase, who should be normally above 200 micrograms of stool. So monitoring these children, we saw that their expression of the disease was not so bad. Only the case 4 has another hospitalization with pseudomonas. Also, they were all mild forms of cystic fibrosis. So metabolic alkalosis in association with low serum electrolyte concentration is not common metabolic disorder in infancy, but it could happen with this also clinical signs. So in Bartter syndrome, the sweat electrolyte profile is normal and the renal handling of electrolyte is defective. In CF, sweat electrolyte losses is increased and intensive electrolyte reabsorption occurs in the renal tubules. So these are the two differences. Okay. They have, I said about the genotype. These are two rare mutations. So G126D and 711 3AG were found in 2 cases, and they are mild mutations. The girl we discovered in 41 years have the same mutations, so she didn't have some big problems. But she has cystic fibrosis. She couldn't have children, so she was divorced, and you know, it is a problem. Conclusion, that any CF patients, either mild or very strong clinical mutations or disease, when we have metabolic alkalosis, we should search for cystic fibrosis, should be considered when they have these biochemical abnormalities, which one can be threatening the life. So we should take the possibility of CF very seriously, and where the metabolic alkalosis is unexplained, and we should test it and find out whether she have it another clinical signs. Thank you very much.